along, we have Dr. Rama Kandasamy, who is going to talk to us about pertussis and pneumococcal epidemiology and vaccination rate and how the landscape has changed and where do we need to focus. He's a paediatrician and immunisation specialist from the Sydney Children's Hospital Network, and his bio is also available, but we'll continue on with the talks. Okay, thank you, Rama.
Great, thank you for the invite to talk. A little less thanks perhaps, Rob, for asking me to talk in 15 minutes on two pathogens which have over a century themselves each of vaccine history, but I'll try and cover it as best as possible. I think they're also, more contemporarily intertwined with the theme of coverage, and also I'll touch on that initially. So coverage for children, particularly over the last 5 years, as you're probably aware, has been dropping. And this graph there over on your left shows quite well, essentially, that gradual drop in coverage, particularly in 12-month-old children with their vaccines. And it's also a theme that you see across the other age groups. Importantly, not just getting vaccines, but getting vaccines on time is another issue. And you can see on this, sorry, I'll go back, subsequent graph that this is really plotting out the timeliness of vaccines. The top blue line is essentially the receipt of on-time second dose of DTP, so that's the 4-month hexavalent vaccine. You can see essentially in 2019 we had numbers in the high 80s, but they've drifted down to the low 80s. This is also the time that we give the second dose of our pneumococcal conjugate vaccine. The other red line shows MMR receipt at 1 year of age. This is also the time that we give the booster now of the pneumococcal conjugate vaccine. You can see also a very similar trend, starting off a bit lower but heading downwards. Importantly, on-time vaccination is key when it comes to generating optimal immune responses. And we know that not only do you have potentially a broader gap in kind of vulnerability, but then also an ongoing persistence that's suboptimal when it comes to immunity if you don't have your vaccines timely. When it comes to antenatal vaccine coverage, important when it comes to the context of pertussis, you can see here from this preprint data from New South Wales. I want you to focus on the blue bars there in that graph, essentially, which show that we started off initially with increasing coverage amongst pregnant women for pertussis-containing vaccine, obviously with national funding starting in 2018. We peaked around 79%, and then we've had this similar theme of gradual decline occurring in subsequent years from 2020. This graph here just shows that a lot of the doses, and this is where the main job is happening, occurs in the GP setting, but obviously there's a variety of antenatal models of care, and we need to think laterally about how we also provide vaccines through those models of care. So pertussis and to I suppose a lesser degree Bordetella parapertussis cause a clinical syndrome akin to whooping cough. The bacterium itself, essentially gram-negative encapsulated Coccobacillus, I suppose graphically looks like this, and it has, I suppose, I draw your attention to a number of surface proteins which we include in our acellular vaccine. Obviously the whole cell vaccine contained a more broader antigen profile. Whooping cough essentially causes this clinical syndrome of paroxysms of coughing, sometimes with subsequent tussive or vomiting episodes, and obviously breath holding. And this is the classic image you see of this kind of protruded tongue, often the colour change in the face of the child, and really very difficult to watch in real life. The fits of coughing with the absence of breathing. The current program for pertussis coverage, I suppose across childhood, starts in pregnancy, as you're aware, and then we have a number of doses through childhood, and then also even into adolescence. to try and limit transmission. As you can see here, pertussis vaccination started in Australia way back in the 20s in terms of development. We've had the wholesale vaccine for a good period here, and a gradual addition of doses throughout the more recent decades, and finally, more recently, the addition of that antenatal dose in 2018. This is probably the most compelling slide when it comes to the pertussis and whooping cough topic. And this really shows the rate of deaths we had due to whooping cough prior to the introduction of vaccination. And it really is the archetype for the success of vaccination amongst our children. And so we had thousands, hundreds per year, thousands of deaths over years prior to the introduction of pertussis vaccination. And this really indicates the success of being able to get this mortality line just down to 1 or 2 deaths per year, and almost a little bit less now that we have quite advanced clinical interventions like ECMO for these children. This also just highlights the importance of, if we stop vaccinating, where we might end up when it comes to these overall mortality rates. Importantly, though, notifications haven't gone down over this time. We've had the progressive introduction and availability of molecular techniques to detect pertussis much better than traditional microbiological culture. And so we've been very good at detecting it, and we've been very good at being able to identify that we have these 3 to 4 yearly peaks in these little outbreaks occurring and notifications. And largely, and this is all just from the national dashboard, largely hospitalisations, which I haven't shown here, follow these notification peaks. You can see, obviously, in more recent history, what's been happening. And this is a combination of factors, probably our little COVID blip and a bit of lack of background immunity occurring across our population, but also increasing molecular testing, increasing adaptation of being able to do PCR on our respiratory panels as well. But it doesn't diminish the fact that we're seeing a lot of pertussis right now and recently over the last year in the clinical setting. So what are some of the challenges? I think obviously there's definitely been some limited vaccine impact on transmission with our current schedule, although we've been obviously working on trying to increase doses across childhood to combat that. There's potentially some blunting due to maternal vaccination. That is, giving a vaccine during pregnancy may reduce the immune response in the infant when they have their vaccines. Now, we still need to watch this space when it comes to that aspect. Some of the studies I've read in terms of modelling that potential outcome say that you need to watch and surveil your disease really for 10 years after introduction of a program. I think there's also the caveat of having had COVID in the very kind of beginnings of our program amongst all of that. Potentially the pathogen is adapting to clinical interventions, as we see for many pathogens, and we need to be closely watching that. We have newer technologies like genome sequencing, which can help us on that front. And then, as everyone's highlighted, this downward momentum in coverage, and really importantly, you saw with that mortality graph, the importance of vaccination in this context with this pathogen is significant. And if we take our foot off the accelerator, I think there could be significant consequences in this context. I've just put some possible solutions, but there's probably many more. When it comes to transmission, there is development of a live attenuated wholesale vaccine given intranasally, so it's more working at that kind of initial contact and infection location, which provides that mucosal immunity and has that wider range of surface proteins. And it's essentially, in the trials I've been involved in, targeting school-age children to try and dampen down those rates of transmission and milder disease, which end up causing that severe disease in those very young infants. I think, as I highlighted, significant needs for ongoing surveillance using newer technologies to help inform whether this is occurring and just how effective our current acellular vaccines are. And importantly, noting that in our infant schedule, we have 2 vaccines which have slightly different profiles when it comes to the antigens included in them. So Influenza Hexa having 3 pertussis antigens and Vaxelis having 5. We need to start thinking about modelling and getting a better sense of whether this blunting's occurring and adapt accordingly. And so that's where this suggestion comes in. And then also we need to, obviously, as we've touched on in the last couple of talks, not only have better understanding of the challenges with our coverage, but start reversing that momentum overall towards increases in overall coverage, particularly in childhood. So I'll move on to pneumococcus, which is a thing close to my heart and an area I've worked in quite a lot. It's the most common cause of bacterial pneumonia and meningitis amongst children. It's also a very common cause, or the most common cause of bacterial pneumonia amongst older adults, sorry for that matter. It's a gram-positive diplococcus. It has this outer sugar capsule or polysaccharide capsule, and it's this, I suppose, the conformity or the shape of this capsule really and how it's recognised by antibodies or our immune system that gives its serotype. And there's over 100 different serotypes, and importantly, the vaccines we have cover a subset of those serotypes. And also, some of these serotypes are more associated with causing disease, others are actually less associated with causing disease and or are carried asymptomatically. High burden of disease, particularly amongst children and older adults. We see hundreds of thousands of deaths still across the world due to pneumococcus, and we still see deaths and significant long-term outcomes from pneumococcus in children, even in our setting. There's been obviously progressive improvements with these numbers over time with the introduction of pneumococcal conjugate vaccines, but there's still a way to go. And I'll also highlight some of the challenges we have. In terms of thinking about pneumococcus and where we can kind of interrupt, I suppose, its transmission and disease profile, I like to kind of show this kind of diagram really. Carriage, or particularly asymptomatic carriage due to pneumococcus, is common. Every other child under 5 will be carrying pneumococcus in the back of their nose, but they don't develop any symptoms, but they may transmit it. And this is an important place where we actually interrupt transmission and indirectly protect others in the population that haven't been vaccinated. And some people might argue that this is a really important reason why we vaccinate our infants in our population. Pneumonia is the most significant burden of disease due to pneumococcus. It's still common in our population. There's no diagnostic test, but it's clearly a very strong reason why we use these vaccines. And invasive pneumococcal disease, which overlaps a little bit with pneumonia, it's not rare, it's infrequent, but it's still meaningful. It's much more frequent than meningococcal disease. Can result in death and often results in lifelong functional impairments, and also clearly a really important reason why we vaccinate across our population, particularly our young children. The vaccination schedule in Australia has evolved initially from a conjugate vaccine, which covered 7 of the serotypes back in the early 2000s, using a 3-dose schedule early in infancy. That moved on to a vaccine which covered 13 serotypes using the same schedule. More recently, we've changed the schedule to have 2 early doses and then a booster dose at 1 year of age. We also have vaccines which cover more serotypes and have recommendations but not funding just yet in our program. I think it's important there's one aspect that's dropped off this slide, but it's important to note that disease is not uniformly spread across the country, and Indigenous Australians are particularly at risk of invasive pneumococcal disease, and so they're recommended to have an additional dose, and also people in at-risk groups are recommended to have an additional dose at diagnosis. In addition, there is the unconjugated or polysaccharide-only 23-valent vaccine, which is recommended to subsequently be given to those populations afterwards. Here I just highlight the evolution of pneumococcal conjugate vaccine development. It initially started off with a wholesale vaccine as well before polysaccharide products were developed. Importantly, it was this aspect which actually was the protein conjugation of Hib polysaccharide to protein, which led to the then translation of that idea to the pneumococcal sphere to develop a pneumococcal conjugate polysaccharide vaccine. And that really propelled the use of these products in children where polysaccharide vaccines are otherwise not particularly immunogenic in younger children. How have they been effective in terms of at least invasive disease, which we measure well now across Australia? Quite effective for PCV7, initially introduced back here in 2005. You see this black line, which is overall invasive disease, rapidly shooting down. But I also remind you, this could be where we could be if we don't have good coverage. This then, stabilised. We had another little dip with the introduction of PCV13, covering a few more problematic serotypes, really involved in invasive disease particularly. And then we've bumped along here, and particularly this green line, which talks about really the other serotypes not covered by a vaccine, has had this little trend, I would suppose, upwards. Maybe it's stabilising. It's something we need to watch in these coming years as to whether this reaches some kind of homeostatic point, or does it continue to trend up? One thing particularly about pneumococcus is it's highly adaptable. It's able to gather DNA and transfer DNA across other strains very easily, and this is part of the reason why you see this serotype shift across disease in many settings that have done exactly what we have with progressive introduction of higher valent vaccines. In terms of those other serotypes that are causing disease amongst the children, this is just a little graph to show that over some of the last decade. Importantly, these two serotypes are not covered by these current vaccines, which have got recommendations, but a number of these other serotypes are. You can see PCV20 kind of stands out with probably covering a few more than PCV15, but ultimately either of those vaccines seem to be giving us some added coverage and benefit there in our context. The other thing to take away is perhaps disease has been shifting a little bit in the age group it's affecting, and this graph is just a little I suppose analysis I've generated from the data on the dashboard and generated these graphs. This is kind of serotypes included in the vaccine, serotypes not included in our current vaccine. But what I want to highlight is probably these dark blue and light blue bars, which are the 2 to 4 and 5 to 9-year-olds. And hopefully I can kind of convince you that they're widening or increasing in size, particularly over these more recent years. And perhaps we're seeing a bit more disease in this age group where the antibody response from having that dose at 1 year has largely dissipated, and we have to think about how we might better coverage this age group perhaps. So what about the future? Clearly there's a growing need to adapt to emergence of new strains not covered by the current PCVs, and I think that's perhaps where we're going in our local setting. I think there's clearly a need also to think about whether we need to better cover some of those slightly older children as well. There's a growing range of different vaccine products, and so it's really important to have that local data, not just invasive disease data, but we need data probably around that carriage and pneumonia context to better understand what is the right timing and what are the right products and or combination of products to use in our setting, because that is all region specific, and what fits one setting or one country is not necessarily going to fit another. I might leave it there and ask for some questions.
Just a bit too quick finishing for me.
I could go on forever, but...
Yeah. No, that's great. So while people are moving to the mics, I have one online question. And this person has asked, has there been a change in the rates of pertussis in infants since the access to vaccines by fathers of an unborn child was removed from the NIP? I'm not sure if it ever was on the NIP, but I think there were some state programs. We certainly had one briefly in Tasmania. Also, since it is now not recommended for extended family members, do you think this has impacted on rates?
I think what became apparent and is very apparent, at least in recent history, is that actually the most important recent recommendation has been the recommendation in the antenatal space. I think there's pretty good data to show that I suppose passive transfer of immunity is really important for covering that first sort of 6 to 8 weeks before they receive their vaccine, and that's the most vulnerable period when it comes to whooping cough. The other aspect when it comes to, I suppose what they're alluding to is the kind of cocooning strategy of vaccinating other close family members. I think importantly there's good data as well showing that actually the mother is often a transmitter to that very young child, obviously the person that's in most close contact with the child, and so interrupting that through maternal vaccine has been another strong facet of and clearly the success of what's been seen in our population. I think it's although there's been that kind of drop away of that recommendation around cocooning, it's still something that is being I suppose loosely practiced. I still think it's something to consider, particularly if you haven't had a tetanus or pertussis dose, and obviously there's rationale not just to have pertussis but tetanus amongst adults as well. I think we're covering children within the family unit pretty well, and so I think it's something to consider, particularly as healthcare providers, just checking those records and think about the contact that those extended members may have.
Yeah, that's certainly something that I find you often have, particularly men who've come in with a workplace injury, and it's often an opportunity to say, well, we're not just giving you a tetanus booster, but we're giving you a pertussis booster as well. Also just checking that they haven't recently become a parent and already had it, and people think about it for the reason they're having it, not that it's a combination vaccination. While I'm asking the next couple of questions, perhaps our other speakers might like to come and join us on stage. But Paul Van Byner has asked you a question, and it is that the 19A does not have the large capsule that the ST3 has. I hope you'll understand what all this means. Why is it still somewhat resistant to PCV 913?
Yeah, great question. Look, I think there's differences beyond the capsule, I think is the short answer. Yes, serotype 3 has some very unique capsular aspects which seem to make it more challenging when it comes to the antibody generated from vaccination to kind of counter. But yes, serotype 19A has been a little bit pesky, I suppose, when it comes to controlling with vaccination. We're still definitely dampening it down, but I think there's a little bit of room for improvement there potentially. I think some of those aspects are clearly not related to obviously its serotype or capsule per se, but its underlying strain and other kind of virulence factors on the surface.
One more online and then we'll go to the ones in the room. Given the reported adaptation of pertussis to vaccines, what do you see as the future approach? That's a big question.
Well, my response is that we need better vaccines. That the concern we've had when we've gone from whole cellular, which were causing lots of reactions, the acellular isn't as good. And as already mentioned, there's a few new vaccines coming through. There's probably going to be a standalone whooping cough vaccine, which when it's available, I think in Thailand and Singapore, if that comes to Australia, then being offering it. So if it's a better vaccine, I think that's a chance to maybe influence it. So I guess while we've got essentially substandard vaccines, then there's still a challenge to how to manage whooping cough.